I come from Johns Hopkins Hospital in the United States. Can you all understand a little bit? Okay, great. It's my pleasure to be here. A big thank you to Dr. Ben Smale for inviting me. So Johns Hopkins is famous for being the first research-driven medical institute in the United States, delivering on the promise of medicine. So I'm going to take a slightly different turn from what you've heard this morning. You've heard amazing lectures about pharmacology and functional anatomy and the role of the cerebellum. But what about what's happening in the muscles? Could some of the peripheral changes be responsible for some of the abnormal movements that we see in the neurologic population? And what exactly in the muscle could be responsible? And do we have treatments? So what I'd like to submit to you is that you can think of the entire motor system as an orchestra. And the nervous system is like the conductor of the orchestra. Clearly, the inputs from the central nervous system to the peripheral nervous system, to the muscles, are extremely important, right? And that's the role of the conductor. But the action is done by the muscles. And so you can imagine if the conductor is dysfunctional, the muscles will be dysfunctional. But it could also happen the other way around, that the muscles are dysfunctional and they contribute to the overall movement dysfunction. So I'm going to talk primarily from experience after a stroke. We know that stroke often leads to a vicious cycle where initially you have hemiplegia or hemiparesis, which leads to weakness. That leads to lack of movement. And then there are changes in the muscles that then lead to contribute to the reduction in the range of motion and the strength and to abnormal movements like your synergy patterns. And so they reinforce each other. The paresis leads to some degree of abnormal movements, but then the changes in the muscles then reinforce those abnormal movements. And we know that these abnormal movements, for example, the spasticity and the synergies, they don't occur right away after the injury. They take time. And so that suggests that there is something else happening during that time. It could be that that something else is happening because of maladaptive circuits from the central nervous system, but it could also be that the maladaptation is happening more peripherally. We know that when we talk about spasticity, it typically presents in the same joints that are responsible for your synergistic movements. For example, in the upper limb, there's the flexor synergy pattern, right? And the spasticity is also in those muscles. So in the elbow flexors, wrist flexors, shoulder internal rotators. Similarly, in the lower limb, there's an extensor synergy pattern. And so the spasticity is more in the ankle plantar flexors, in the knee extensors. Also, we see that the greater the severity of paresis and the greater the sensory dysfunction, the more severe the spasticity, right? Suggesting that whatever is happening centrally, or not happening, right? So lack of input from the motor system and from the peripheral sensory system, the greater the changes in the peripheral system as well. Also, the greater the degree of weakness, or for example, if you have a hemorrhagic stroke, you may have a more severe deficit, and as a result, there is more severe spasticity. So people have published a lot on what are the predictors of spasticity in the long term, for example, at 6 months. And clearly you find that lack of input from the central nervous system, for example, from a hemorrhagic stroke, more severe stroke, or also from excitation, for example, with the use of SSRIs, can lead to spasticity. What that suggests is that you could have changes in the muscles from the lack of input, or that when we have excessive input, then also there could be changes, because it's very difficult to distinguish between voluntary excitation and involuntary excitation. So the bottom line is that the central nervous system is clearly plastic, but there is plasticity occurring in the skeletal muscles as well, right? And they are also subject to the principles of use it or lose it. And so what are these changes in the muscles that are responsive to the lack of central nervous system input and that then cause downstream disability? So we know that the stretch reflex is like your common pathway to the muscles. And we know that there are descending influences on the stretch reflex. These descending influences can be excitatory or inhibitory. Usually there's an imbalance between excitation and inhibition after a central nervous system lesion. And as a result of that, there are changes in the stretch reflexes. The stretch reflex begins with the ability of the muscle spindles, the receptors inside the muscle, to sense the change in length of the muscle. And that input is projected into the spinal cord interneuronal network. And then, because of the lack of inhibitory and excitatory balance, you usually have a lack of suppression of the stretch reflex in patients with spasticity. That can lead to muscle overactivity. And ultimately, most of our treatments address this muscle overactivity, either by trying to reduce the overactivity at the muscle itself, for example, with botulinum toxin treatments, or we reduce the input to the muscle, for example, by doing motor nerve blocks, or by reducing the output of the central nervous system by giving intrathecal baclofen or suppressing the central nervous system. And occasionally we may do surgery like dorsal rhizotomy to actually reduce the sensory input from the periphery to the spinal cord network. But what we find is if we actually measure the EMG activity coming from the muscles in patients with spasticity, when we try to elicit a stretch reflex, for example, by moving them at different speeds, we find that not everybody has muscle overactivity. So, for example, here we have patients with different degrees of spasticity measured by the modified Ashworth scale. Right? We know the modified Ashworth scale is not perfect. It does not measure the velocity dependence, but we see that patients could have different degrees of modified Ashworth score with different degrees of spasticity. But approximately half the patients who had resistance when you moved them did not actually have muscle overactivity, right? So you can see that some patients, the person in green here, has muscle overactivity shown by the EMG, but this other patient here had very little muscle overactivity, right? And similarly, even with different degrees of modified Ashworth score, you see that there are some patients who don't have much overactivity. So even in patients who got botulinum toxin, what you see is sometimes the muscle activity reduces, but the actual resistance does not change. Okay, suggesting that there could be something else going on in the muscle that is producing resistance, but it is not leading to muscle overactivity. Now, it's not a new idea. Other people have also said that there is the effect of the central nervous system on reflex function, but there's also the effect on muscle function. And usually that is due to altered muscle mechanical properties. And it is the combination that leads to your spastic movement disorder or even your clinical spasticity, which is seen in the passive situation. Just when you move the patient, not when the patient is moving by themselves. And here in France, Marjolaine Baud and Jean-Michel Gracies have published a lot on the muscle disorder or spastic myopathy that has a very high deforming capacity, and that is actually responsible for a lot of the problems that we see, besides the muscle overactivity, the spastic dystonia, and the co-contraction. So, what could be happening in the muscle? So, as we just discussed, the muscle spindle senses the change in length, which is really important to activate the stretch reflex. Now, the muscle spindle is situated not inside each muscle fiber, but in the perimysium or the extracellular matrix of the muscle. So as we know, the muscle is made up of the muscle fibers, and then around the muscle fibers, you have collagen, your endomysium, which is right around each muscle fiber, your perimysium, which is around the muscle fiber bundles, and the epimysium, which is on the periphery. And if you dissolve the muscle fiber with sodium hydroxide, as shown in this slide, you can see this collagenous matrix very nicely. And we know that in individuals with spasticity, especially chronic spasticity, for example, after cerebral palsy, these muscle fiber, actually the collagen is thickened, right? And you can see that in red here, with the Sirius red staining, or even with the hematoxylin eosin staining. But right around the collagen, you have a sugar molecule, which is the ground substance of the muscle, and you can stain it with, it's called hyaluronan or hyaluronic acid, and you can stain it with hyaluronic acid binding protein. It stains brown. So all this brown that you're seeing on your slide is actually hyaluronic acid in the perimysium. You see there's a lot of it, and also in the endomysium. And this is where, in the perimysium, is where you have the muscle spindles, right? So, and you know that it is hyaluronic acid because you can dissolve it with the enzyme hyaluronidase. Okay, so this slide shows you the structures. So you see the muscle spindle, which is circled in red, but with hyaluronic acid binding protein staining, which is HABP, you see that there is a lot of hyaluronic acid inside the muscle spindle in the normal situation, and then you have some hyaluronic acid outside as well. Okay. The next structure is your nerve fibers, which are entering the muscle. And you see that around the nerve fibers also, you have a lot of hyaluronic acid. Now, what Pedroso Domelov showed back in 1998 is that relationship between the hyaluronic acid inside these structures or around these structures and in the perimysium is actually really important, especially to sense the degree of stretch. So what is hyaluronic acid? Okay. What we know is that hyaluronic acid, also known as hyaluronan, is a sugar molecule which is a byproduct of glucose metabolism. It is made up of repeating disaccharide units of glucuronic acid and N-acetyl glucosamine, and it forms a polymer, but it also binds to water and forms a very complex molecule, which can have very high molecular weight. Hyaluronic acid is produced inside the muscle by hyaluronic acid synthase enzymes, which are extremely sensitive to mechanical input. So lack of movement and also a lot of movement. And then once the hyaluronic acid is synthesized, it is extruded into the extracellular space in the muscle. And so in normal quantities, it forms a thin layer between your muscle fibers, right? So you can imagine that you have two muscle fibers and you have this thin layer. And in normal conditions, it facilitates sliding and force transmission, because when we move, we know that the shape of the muscle is not, the muscle fibers are not parallel in all muscles. They are pennate shaped. Most muscles are pennate shaped. The muscle fibers are arranged in a pennate shape. And so the force that is generated at one end of the muscle has to be transmitted to the other end, and that occurs due to this sliding. But what happens is, because of immobility, and this has been shown in the rat soleus, right? You can see the hyaluronic acid staining in the rat soleus muscle in the normal case, and then they immobilized the ankle joint and then found that there is increased accumulation of hyaluronic acid. They also looked at the structure of the endomysium with scanning electron micrography. And what you see is that in the normal case, the endomysium looks like separated strands, like well cooked, with properly cooked spaghetti. Okay? But when you have a lot of hyaluronic acid, then it almost seems like the endomysium is stuck together, like overcooked spaghetti. Okay? And so this is histological section seen in an animal model. But if you look now, we can use something called T1-row MRI to quantify the hyaluronic acid accumulation in individuals with post-stroke stiffness. Okay, so for example, here you see in the control case, the color bar shows you the concentration of hyaluronic acid. More red means more concentration. Okay, and this is shown by the relaxation time of T1-row MRI. So you see in the normal case, the relaxation time is approximately 25 milliseconds, suggesting there is some amount of hyaluronic acid. But in the patient with post-stroke muscle stiffness, you see it is much more increased. All this red suggests very high concentration of hyaluronic acid. And you can see that the shape of the muscle is almost triangular, right? It's not circular. This is the shape of the upper arm. And this suggests that the muscle fibers are stuck together. Okay? Now it's been shown that as the concentration of hyaluronic acid increases, the viscosity of the fluid increases exponentially. Okay? So now you can imagine that when the viscosity is increased, it becomes very thick. So you know that already the hyaluronic acid binds to water and becomes a somewhat viscous molecule, and that's the lubricant in the muscle. But when there's increased concentration of hyaluronic acid, then the viscosity of the extracellular matrix can increase a lot. and that can reduce lubrication and tissue sliding. Okay. Now, the hyaluronic acid can form almost solid-like structures like globules and sheets. And when that happens, you have this thick layer between your muscle fibers. So even if the muscle fiber is generating some force, the force may not be transmitted easily from one end of the muscle to the other because the sliding is reduced. Okay? The muscle fibers are literally stuck together, and if you try to move the muscle, you notice resistance. Okay. Also, if the individual is trying to move themselves, then they have to fight against this resistance and maybe produce more muscle activity. Now, it's been found that this key change in the extracellular matrix, which can eventually lead to fibrosis, is in the extracellular matrix. So this was a rat study, and Dr. Jean-Michel Gracies was part of the study team, where what they did was they looked at the control muscle, they looked at the immobilized muscle, they looked at the stroke muscle, and stroke immobilized muscle. And what they really found was it was not so much the stroke, but it was the immobilization that led to these changes in the extracellular matrix. Right? So now what I was just trying to share with you is that actually, so here in the previous slide, they were quantifying the thickness of the extracellular matrix, primarily the collagen. Right? So what is the relationship between the hyaluronic acid accumulation and the collagen deposition that leads to fibrosis? Well, it's been found that hyaluronic acid is in the extracellular matrix, not just of the muscle, but in the liver, kidney, lung, in all the organs. And when the concentration of hyaluronic acid increases, that leads to a conversion of the fibroblast to the myofibroblast phenotype. And it is these myofibroblasts that lead to the deposition of collagen and fibrosis, right? So once you have fibrosis, then the condition is irreversible. But if you have deposition of hyaluronic acid and you can decrease the accumulation of hyaluronic acid, then it is potentially reversible and you can prevent the progression to fibrosis, right? So this provides a window of opportunity where you have stiffness but not yet contracture. So potentially this is a target for treatment where you are treating the increased extracellular matrix viscosity and potentially disrupting this cascade of active muscle stiffness due to muscle shortening, neurally mediated reflex muscle stiffness because now your muscle spindle is properly responsive, it's not excessively sensitive to stretch, and even passive muscle stiffness, which may be due to contracture. So the idea here is that the muscle, you can think of the muscle as a spring. The muscle can produce passive force. So if you push the spring, then there is a passive force that is pushing back. If you pull the spring, then there is also a passive force generated that is pulling the muscle. Now, typically you need optimal muscle length for optimal muscle function, right? Because it has to be sensitive to both the pushing and the pulling. But if a muscle is stuck in a shortened position, then you can have increased generation of passive tension because of a shift to the left, right? So what can we do to restore the springiness in the muscle? So what is the first line of treatment? It is actually rehabilitation or the prevention of immobility, right? Which is where all your rehabilitation techniques, physiotherapy come into place because, as I shared with you before, a lot of the changes are because of the severity of the stroke and the lack of input. So physical therapy and movement is extremely important. And that has to be early. So early rehabilitation is extremely critical. Which movements do you treat? Well, primarily the anti-synergy movements, because we showed that the spasticity is greater in the movements that are responsible for your synergies. And the synergies may occur because, we tend to remain in these positions. So in the arm, we tend to stay internally rotated, elbow flexed, in the normal immobilized position. And in the leg, there's plantar flexion and knee extension if you're lying in bed. So if you want to reverse engineer movement, you have to promote muscle activity, but then you also have to promote movement in the out of synergy direction, starting with single joint alternating movements, and even with active passive movements where, even if there's no active joint movement, you're moving it passively so that you have normal sensory feedback to the greatest extent possible. Which movements should you avoid? Well, compensatory movements can potentially also lead to stiffness. How? Because, so this was a study done in a mouse model where they cut the tendon of the soleus, right? They cut the Achilles tendon, but the mouse was still running. And so they looked at the plantaris muscle. And what they found was that the plantaris muscle shows increased production of hyaluronic acid 2 days afterwards, right? So in other words, if you have increased compensatory activation of other muscles, they will also generate more hyaluronic acid. Now, if the animal is moving, then what will happen is the amount of hyaluronic acid will become normalized because of homeostasis. But you can imagine that if the animal stops moving because of paresis, so you're giving a lot of activity and then very little activity, then there could be increased production but not increased metabolism, and you will have accumulation. And in this case, you can measure, again, this is a case of tennis elbow or lateral epicondylitis due to overuse. And once again, you see all that red in the periphery. That's hyaluronic acid accumulation measured by MRI. Okay, so we published a textbook which is more generally about spasticity and muscle stiffness, but we talk about the role of hyaluronan accumulation. So basically, consistent movement, not too much too soon, is perhaps the most important treatment. Now, there was this very interesting study, small study, randomized controlled trial, where they did myofascial release. So it turns out that on the one hand, you have spasticity, but in people who don't have a neurologic condition, you may have overuse, which can also produce hyaluronic acid and can cause myofascial dysfunction. And so you can use mechanical treatments to break down this hyaluronic acid potentially, like myofascial release. So what they found was conventional treatment and plus myofascial release both led to improvement, but the relative improvement shown in the bottom table was greater with the myofascial release in addition to conventional therapy with a very high effect size of almost 1. Okay. What else can we do, right? So basically, there are many passive techniques that can be used to break this vicious cycle, like proper positioning, like movement, vibration, shockwave, dry needling, acupuncture, fasciotomy. Now, we don't have enough evidence quite as yet that they all change hyaluronan homeostasis, but this is a hypothesis to be tested. But what we do know is that there is hyaluronidase that is present in vivo. But typically it is present inside the muscle cell, and the hyaluronic acid has to be taken back into the muscle to be broken down by the intramuscular hyaluronidase. Right? But what we can do is we can give hyaluronidase intramuscularly, and so this is something we have published, and that can then lead to increased passive and active range of motion. And currently we are doing a randomized controlled trial, and what we see is that the EMG activity in the affected side is increased, but after hyaluronidase treatment it is decreased. Similarly, with the Tardu test, it is increased and then it is decreased. Even in patients who don't have very severe overactivity, the y-axis is very small here, you see a decrease, suggesting that this relationship between the hyaluronic acid inside and outside the spindle may be really important. And so hyaluronidase is a potential treatment in the future that still needs to be studied. And with that, I will summarize that maybe immobility and compensatory movements can lead to peripheral changes in the muscle. Hyaluronan may be a key mediator, and we can perhaps break this vicious cycle. I'd like to acknowledge my lab and collaborators and the clinical trial team. Thank you for your attention.
Thank you for this great presentation. Est-ce qu'il y a des questions?
I have a question. Yes. Please. Do you think that it could have a different hypothesis on the nature of a contractor from one etiology from the other etiology? For example, do you think it's really different in CP, cerebral palsy, than in stroke patient for the nature of contractor? And the other point that you don't have speak about satellite cells in stroke muscle, which seems to be very important in cerebral palsy physiopathology of contractor.
Yeah, thank you for that excellent question. So we are currently doing a randomized controlled trial in stroke. However, in the study that we published in 2016, it was a case series where we had a mixed population of stroke, traumatic brain injury, cerebral palsy, and we are seeing that the pathophysiology is similar. Right? So there is a potential, it has to be tested, but that we can change the pathophysiology of contracture and fibrosis even in cerebral palsy. But what about the satellite cells, right? So in the textbook, there is a chapter on satellite cell dysfunction. We do not know yet if this potential treatment can change the function of the satellite cells. Potentially, because they are there and they are dormant, they could be activated to improve the morphology of the muscle.
Merci. On va faire la pause parce qu'on a un petit peu de retard et on reprend à 11h30, mais soyez là un petit peu avant.